Well, thank you, David. I'm just really honored that I'd have this chance to be with a group of people like you, and I hope that my thoughts prove to be useful to you. My first career was I had founded and run a company with a bunch of MIT professors in the Boston area to commercialize some materials technology that they had developed. The company has become quite successful, but I always had wanted to be a teacher. So as the company began to hit its stride and I was hitting age 40, we just decided if I was ever going to do it, I better do it. So we put the VP in charge, and I bailed out and became a doctoral student all over again with 5 kids. Looking back on it, it was kind of stupid, but it's been a fun career for me to have this second chance and be an academic. I brought with me a set of puzzles as I left the company to go into academia. One of the puzzles was, I wonder why success is so hard to sustain. If you look across the sweep of business history, most companies which at one point were regarded as unassailably successful, a decade or two later you find them in the middle of the pack, often at the bottom of the heap. And the other companion puzzle was, why does innovation seem to be so risky and unpredictable? You know, for example, every time venture capitalists put money into a company, they think it will succeed, but statistically, only 1 to 2 out of 10 actually become successful. And the track record of established companies in launching new innovations into their markets isn't much better. Every time they invest to create a new growth product or business, they think it will succeed. But for them, statistically, only about 2 out of 10 make it. So the puzzle was, I wonder if innovation is just is intrinsically unpredictable. And if that's the case, then you turn to chaos theory and a few things to manage it better. But maybe it's unpredictable because we just haven't figured out how to teach it and manage it well. And we really came to the conclusion that the reason why success is so hard to sustain and why innovation is such a crapshoot is attributed to the principles of good management that are taught at the leading business schools such as Harvard. In other words, the fault really lies with us and faulty research that we've been doing. So I've spent my career in academia studying these problems of innovation. And about 10 years ago, I was just innocently minding my own business in my office. Got a visit from Jerry Grossman, who at the time was the CEO of the Tufts New England Medical Center in Boston, and Liz Armstrong, who teaches at the Harvard Medical School. And they brought a proposition. It was, you know, everybody's been studying healthcare to reach conclusions about healthcare. At their core, these challenges of making it affordable and accessible are problems of innovation. Maybe if you just join with us and look at the healthcare industry through the lenses of your work on innovation, maybe you'd be able to see a few things that others haven't been able to see. And so I naively signed up. It took 10 years to get to the point where we had something that was publishable that we weren't ashamed of. And that's what I'd like to just summarize for you today. We wrote a book about this called The Innovator's Prescription. That will be able to give more detail for those of you who are interested in more than we can present in this next hour. It turns out that the problem that we face in healthcare, that is, it is just so expensive and so inaccessible that it's available to fewer and fewer people, isn't at all unique to healthcare. Almost every industry at some point in its past was characterized by products that were inaccessible and too expensive and complicated. You can almost depict the history of lots of these industries in the form of a set of concentric circles, where the innermost circle represents people with lots of money and lots of skill, and the outermost one represents the unwashed masses. And at the beginning of the computing industry, as an example, I carried my slide rule everywhere. Whenever I ran into a problem, I whipped it out, did the estimation, wrote it down, got on with life. But in this industry, as in most, when sophisticated technology emerges in the industry, it drives a centralization. And in the case of computing, that first manifestation of digital computing was the mainframe computer. And those of you with a bit of gray hair would remember that these mainframes filled a whole room, cost several $1 million to buy, and took many years of training to be able to operate them. And so only the biggest universities and the biggest corporations could have one. We then had to take our problems to the solution in the form of a set of punched cards where an expert ran the job for us. But the very inconvenience and cost of that then drove a process of decentralization, which happened in computing and has happened in most industries. So the first step in decentralizing the computing industry was a machine that we called a mini computer. And you got to have gray hair to remember these things too. We called them mini because they were a lot smaller than mainframes. But they're the size of a small filing cabinet. They reduced the cost from $2 million to $200,000. And they made it so simple and affordable that engineers could now have mini computers in their own departments. At the beginning, you could only do the simplest of computing problems on the mini computer. You had to take the complicated ones to the mainframe. But as the mini computer got better and better and better, you could do more and more things on that simpler computer that previously had required the mainframe. Then the next step was the personal computer. It made it so affordable and so simple that even a fool like Clay Christensen could have one in his office and in his home. And at the beginning, we could only do the simplest of things on that platform, typing and spreadsheet analysis. And we still had to take the complicated problems to the mini and the mainframe to resolve. But as that PC platform just kept improving and improving and improving, one by one, we could do on that platform the things that previously had required much more expensive mainframe computers, until ultimately we just didn't need mainframes and minis anymore. And now the notebook computer puts computing in our briefcase, and the notebook is getting good enough that a lot of us don't have that old clunky desktop or under the table box anymore, because the notebook can do everything that we need. And then the handheld device puts it in our pocket or our purse. And every one of these steps improved accessibility and the cost of computing, not by cost reducing the mainframe, but by creating a fundamentally different platform, and then have that platform start on the simplest problems and then get better and better, so that ultimately it obviated the need for the higher cost platforms. And this is the mechanism by which computing became affordable and accessible to all. Well, as we've studied this problem, the reason why this happens is there's great opportunity in making it simple and affordable. But we've also observed that the companies that were the leaders in their industry in those innermost circles rarely became the leaders in the next circle out. And the explanation for this came from a model that emerged in our research called disruption. And I'd like to just explain the model for a minute, then apply that model to computing, and then I'd like to get to applying this model to the future of healthcare. So you can plot on the vertical axis of any industry the performance of a service or a product over time. There are two elements of the model. The first is, in every market, there is a trajectory of improvement that customers are able to utilize. Now, there's always a distribution, so at the high end, very demanding people with really complicated problems, they will never be satisfied with the best that we could offer them. At the bottom of the market, there are simple people with simple problems. They can be oversatisfied with almost nothing. So that's the first element of the model, is there's a trajectory of improvement that customers can utilize in every market. The second element is there's a different trajectory of improvement that innovating companies provide as they keep introducing better and better products. The most important finding about this is this trajectory of technological improvement almost always outstrips the ability of customers to use the improvement. And a good way to visualize that is if you go back to the left-hand side of that diagram in the history of computing in the mid-1980s. Remember when we were first learning to do word processing on those early personal computers? Do you remember how often you had to stop your fingers to let Intel's 286 chip catch up? Because Intel's fastest chip wasn't even fast enough to keep pace with our fingers. But as Intel kept moving up that blue trajectory, introducing faster and faster chips that it could sell for better prices to more demanding customers, by the time they got to a 3 gigahertz Pentium 4 a few years ago, they had shot way beyond the speed that most customers in mainstream applications could use. Now, as companies move up that trajectory of performance improvement, a lot of the innovations that drive it are just incremental year-to-year improvements. Others, however, are dramatic breakthrough innovations. So in healthcare, X-rays were being incrementally improved for many years, and then CAT scanning represented a dramatic breakthrough improvement. Then MRI technology was another dramatic breakthrough, PET scanning yet another. But what we found is that the purpose of the breakthroughs and the purpose of the incremental ones from the point of view of the competitors was actually the same, in that what they were trying to do is to sustain that trajectory of performance improvement that they were on. And we found that almost invariably, the companies that led the industry on the left-hand side of the diagram, before these battles of sustaining innovation began, found themselves still on top of the industry when those battles were over. And it really doesn't matter technologically how difficult it is. It just seems as if the purpose of the innovation will help the leaders in the industry make better products that they could sell for better profits to their best customers. They figure out how to get it done time after time. We observed, though, that there was a different kind of innovation that came into an industry, and we called this one a disruptive innovation. And we used the word disruptive not because it was a breakthrough improvement on the blue chart, but rather than sustain that trajectory, it disrupted it by bringing to the market a product that was actually not as good as the ones the people in the blue were making. But this one is a lot simpler and a lot more affordable, so it could take root amongst a new population of people who previously hadn't had enough money or skill to use what had been available. And then it improves in that context like the personal computer did, little by little, and it draws applications from the more expensive, complicated plane into this new one. Now, what we found is that almost invariably, a new company came in and displaced the old leader when one of these disruptions emerged. And again, the disruption was a simplifying technology that made it more affordable. It wasn't a dramatic breakthrough that made things more complicated. Now, this model was just a big help to me in understanding a puzzle that had plagued me for years, just living in the Boston area. Do any of you remember this big mini computer company called Digital Equipment Corporation? Through the 1970s and 80s, Digital was probably the most widely admired company in the world economy. And whenever you read explanations about why Digital was so successful, always it was attributed to the brilliance of their management team. And they were really very good. Then about 1988, Digital just fell off the cliff and began to unravel very quickly. And when you then read explanations in the business press about why they had stumbled so badly, always it was attributed to the ineptitude of the management team. And it made me wonder, how could good managers get that rotten that fast? But that's the explanation most people accept whenever a company stumbles like that. But the reason the stupid management hypothesis just didn't feel right is every mini computer company in the world collapsed in unison. It wasn't just Digital, but Data General, Prime, Wang, Nixdorf, Hewlett-Packard, Honeywell. And you'd expect these guys to collude on price occasionally, but to collude to collapse was a stretch. There just had to be something more fundamental going on. And this model really helped me understand why the leaders in one of those center circles in this diagram have a very hard time with the kind of simplifying, affordability enhancing improvements that we call disruption. So Digital made these boxes that we called mini computers, again, that were about the size of a filing cabinet. They were expensive, cost $250,000 to sell, so they had to be sold direct to the users. And the selling process involved a lot of training, support, and service. You just had to have costs like that in the business to play in the mini computer game. Given that kind of cost structure, they had to generate about 45% gross margins on machines that sold for $250,000. And that's how those guys made their money. Now, in their environment in the 1980s, as in every company's environment every year, people were walking into senior management all the time with ideas to invest in new products. Some of the ideas that were being floated entailed having digital move up to the top of that blue trajectory to make better mini computers than they had ever made before. In fact, these would become so good that they could start to draw applications from the world of mainframes onto the mini computer platform. If you look at those business plans, they promise gross margins of 60%, and you could earn 60% on machines that sold for $250,000. Well, while management was just trying to decide whether they should invest in those machines, there were a lot of people coming in saying, no, you guys don't get it. That's the wrong direction. Look out the window. There are personal computers everywhere. That's where the future is. Well, when management looked out the window, indeed they could see PCs, but they saw a couple of other things as well. First, do you remember how crummy those early personal computers were? In fact, Apple sold the Apple II as a toy to children. Not a single one of Digital's customers could even use a personal computer for the first 10 years that they were in the market. And that meant that the more carefully they listened to their customers, they got no signal that the PC mattered because, in fact, it didn't to them. But it could take root out in that remote environment and then little by little improve and begin to draw applications into it. And then when they looked at the business plans for the PCs, it got a lot worse, because in the best of years, they promised gross margins of 40%. They were headed to 20% quickly, and you could only earn those paltry percentages on computers that sold for $2,000. And so really the choice the management had to make was, I wonder if we ought to invest to make better products that we could sell for better profits to our best customers. On the other hand, I wonder if we should make worse products that none of our customers would buy that would wreck our profit margins. What should we do? And it really is a dilemma, because these principles of good management that we teach at schools like Harvard provide very good guidance to companies as they move up that blue trajectory. And that is, you should always listen to your customers, and you should always invest where profit margins are most attractive. But whenever one of these disruptions emerge that transform a complicated, expensive product into one that is simple and affordable, those principles of good management typically paralyze the leaders and cause them not to be able to move in the new direction. And I just invite you to look through the lenses of this model whenever you see a leading company stumble. And it's just been very helpful to me to understand how affordability comes into an industry and why it's hard for the leaders to drive that. For example, the next time you read a story about General Motors, try to think through, how did Toyota beat General Motors? Not by introducing Lexuses at the beginning, but do you remember in the 60s, Toyota came into the market with these rusty little subcompacts that they labeled a Corona? And then they went from a Corona to Tercel, to a Corolla, to a Camry, to an Avalon, to a 4Runner, and then to a Lexus. And every once in a while, General Motors, back in the blue space, making big, expensive cars, would look down at Toyota coming up at them, and they'd say, you know, we ought to go compete against those buggers. And so they'd send out a Chevette or a Pinto. But then they would compare the profitability of those little subcompacts with the profitability of an F-150 pickup or a Cadillac Escalade. And it just didn't make sense to defend the least profitable end of the business when they had the privilege of making bigger, higher margin, higher priced cars. And of course, now it makes consummate sense that they should have worried about this 20 years ago, but their game is about over. Who's disrupting Toyota? They do not feel as if they're being disrupted, incidentally. But it's the Koreans. Hyundai and Kia have taken the subcompact end of the business from Toyota, not because Toyota's asleep at the switch, but why would they ever invest to defend the least profitable end of the business when they have the privilege of competing with Mercedes and luxury vehicles? And then you have Chery coming from China and the Nano coming from India. Nobody's got to worry about them ever seriously. And we could just go on and on, that the growth in almost every industry is generated by these disruptors making things simple and affordable. Now, we learned something about competition that had just never occurred to me before because my training had been in materials science and economics. And that is that in any one of these circles, competitors with comparable business models, as they compete against each other, very often, especially in service-based industries, head-on competition has the effect of driving prices up and not down. And I'd always had this view that competition always drives prices down, but it's just not so. So, for example, in the Boston area, 25 years ago, the Mass General actually didn't offer maternity and obstetrics. But in order to compete, to get the big blanket contracts from the insurance companies, they had to add those capabilities. Then the Brigham and Women's didn't offer oncology, but in order to compete, they had to add that capability to their portfolio. And so head-on competition amongst the leading providers of healthcare keeps driving prices up to bigger and better things because that's where the margins are. As soon as one has an MRI machine, everybody has to have an MRI. Now when you drive to work in Boston listening to news radio, the Boston University Medical Center trumpets the fact that they're the only hospital in Boston that has one of those Da Vinci surgical robots. And when you get prostate cancer, come to us because we can do a better job than anyone else. And you just know that all the other hospitals are figuring out how can they have a surgical robot in order to compete. Or those of you with enough gray hair to remember or to have put kids through college, go back 30 years ago and think about what the food service facilities were in a typical college 30 years ago versus the opulent food courts that we have today. Or what kind of facilities did colleges have 30 years ago for students to exercise or participate in athletics versus the kinds of facilities that they have today. And the colleges have just made their campuses more and more opulent, raising the fixed cost structure. But Harvard has to do it if it's going to compete against Stanford. And so head-on competition amongst comparable business models, whether they be universities or hotels or hospitals, actually has the effect of driving prices up and not down. And that's the key reason why healthcare costs keep going up. It's the disruptive innovations that drive that decentralization that are the key to making expensive, inaccessible technologies affordable. Now, I think that you could say this process of decentralization is just beginning to happen in healthcare. When I was a little guy, our doctor made house calls, but then the advent of sophisticated healthcare technology has driven a centralization of the industry. So instead of the solution coming to the problem has to be taken to the solution. I was on the board of the Brigham and Women's Hospital that had a strategy committee on the board where I served for about 10 years. And we did a study once with one of my colleagues there that concluded that about 70% of the patients in the Brigham today would have been in the ICU 30 years ago. And about 70% of the patients in the ICU would have been dead 30 years ago. In terms of our model of disruption, we had become so good at doing miraculous things that we'd actually overshot the amount of care that mainstream patients with mainstream diseases could use when they got admitted to the hospital, and yet they had to pay for what they couldn't use, just like we pay for the functionality on an Intel chip that we can't use. And so it raised the question in my mind, I wonder if healthcare can become affordable by expecting these expensive hospitals to become cheap. Or I wonder if the key to affordability is to ask the specialist physicians who practice there to take pay cuts. It just won't happen. But rather what we have to do is drive the disruption or the decentralization of the industry. And so rather than expecting hospitals to become cheap, we need to bring technology to outpatient clinics. So we can do there the simplest of the things that today require the higher cost hospital And then keep driving that technology so those clinics become more and more capable of doing better and better things. And then we need to bring technology to doctors' offices so we can do there the simplest of the things that today require referral to a clinic, and then keep driving the technology so we can do in that venue more and more. And then the same thing to patients' homes. And rather than somehow expecting that healthcare will become affordable by controlling doctors' compensation, we need to bring technology to primary care doctors so they can do the simplest of the things that today they have to refer to a more expensive specialist. And then keep driving that technology so the primary care docs can do more and more and more. And then rather than expect them to take pay cuts, we need to bring technology to nurse practitioners and physicians' assistants so they can do the simplest of the things that today require a doctor, and then they can do more and more sophisticated things. And so it really is the theme of this conference, this morning, and that is we need to rethink the roles that the various venues and the various caregivers play, because it's only by enabling lower cost venues of care and lower cost caregivers to do more sophisticated things. That's the mechanism by which healthcare can become affordable and accessible, not by somehow hoping that a miracle will occur and the expensive ones will become cheap. Now, when one of these disruptions emerges, or the opportunity to do it, there really have to be three enablers that fall into place quite quickly, that enable a lower cost venue of care and a lower cost caregiver to do more sophisticated things without compromising quality. And the first one is that there is a simplifying technology that transforms the industry's basic technical problem from something that only experts could do to something that is quite rules-based. In computing, that simplifying technology was the microprocessor. Prior to that, it took big teams of people who were highly trained, intuitively skilled engineers. It took them 4 years to design a big mainframe computer. And the processor made it so simple that even Michael Dell could just design and slap together a computer in his University of Texas dorm room. So that's the first thing that has to be in place. The second is it has to be embedded in a business model that can carry that simple solution to the targeted customers in a cost-effective way. And then the business model itself has to be embedded in what we call a new value network, or an ecosystem of suppliers, distributors, and customers whose economics are consistent with the new lower cost business model. Let me talk about each of these three to give you a better sense for what we mean. To do it, I think I'll go through the history of synthetic fibers. 70 years ago, if you needed a new synthetic fiber, there are only about 50 people in the whole world that had the expertise to design one of those molecules, and DuPont employed almost all of them. And these experts would just draw down on their deepest intuition and experience, mix up a few atoms in a beaker, stir it, heat it up, draw out a fiber, look at it under a microscope, go down the hall, talk to a colleague and ask, "Any idea what I just invented?" And she'd say, "No, but bring it in, let's heat it up for 10 more minutes and see what happens." And the miracle molecules that we know as nylon, Kevlar, polyester, and acetate emerged from the labs at DuPont through the trial and error experimentation of the world's best scientists. And that's typical of most industries. The technical problems initially require that kind of trial and error, intuitive problem solving. But as those artists practiced their craft in the fibers industry, patterns began to emerge. And that allowed them to teach other people how to build these molecules. There was not a cookbook yet, but it allowed them to express the outcomes in terms of probabilities. And what that meant is you didn't have to be the best in the world to play in that game. That enabled a lot more companies to enter that industry. And then quantum theory, rate theory, and a bunch of other pieces of understanding fell into place and began to be better understood and applied. And that allowed people to predict in advance what kind of molecules were feasible and not feasible. And then once you had constructed a molecule of a given structure, you could predict what its properties were going to be even before you designed the molecule. That allowed you to write a piece of software so that you just had to type in the properties you needed, and then the software would help you reverse engineer the structure of a molecule that would come as close as possible to yielding the properties that you need. And so today you really just need an MS in Chemie from an average state school and one of these pieces of software, and you can design better molecules faster and at lower cost than could the world's experts a generation ago. So at some point in today's festivities, I just invite you to stand up and turn around 360 degrees. You'll be able to put your eyes or your fingers on probably 24 different fibers that have proven just to be an unmitigated blessing in our lives in terms of their cost, their durability, their performance, their flexibility, their appearance. But that blessing has not come by replicating the expertise of DuPont scientists. It's come by commoditizing their expertise through scientific progress. And where I've come down, although it's an uncomfortable message for medical doctors at academic centers, is that healthcare won't become affordable and accessible by replicating their expertise and intuition, but rather we have to commoditize their expertise. And there's scientific progress underway that actually is making that happen for the simplest of the diseases. And here's the way that I came to frame it. It just turns out that one of the problems in the way God designed the world is that our bodies have very limited vocabularies that they can draw upon to express that something has gone wrong. And the vocabulary are physical symptoms. There just aren't enough symptoms to go around for all the diseases that exist. And so the diseases had to get together and agree to share symptoms. The problem that creates is we most readily diagnose a disease by its symptomatic manifestation without a sense of what caused that symptom. And so when diseases are sharing symptoms, you diagnose a patient with a particular symptom, apply a therapy, and she might respond. And then you have another patient who has the very same symptoms, you give them the very same therapy, and he won't respond. And so rules-based therapy is actually impossible in a world which we call, as we've said on the left, the practice of intuitive medicine. Rules-based medicine is impossible when diagnosis and treatment is dependent upon this judgment and skill of physicians. All medicine began in the realm of intuitive medicine. But as we see more and more of these kinds of problems, medicine can shift into a realm that we call empirical medicine. Others would call it evidence-based medicine. We chose to call it empirical because that really is what it is. We're expressing the probabilities of an outcome, and the evidence is just not perfectly clear yet. Then that allows physicians with less intuition to actually do a good job following what offers the highest probability of the results that we need. But then as we come to be able to diagnose diseases by their cause rather than by their symptom, the ability to precisely diagnose is a precondition, generally, for the development of a predictably effective therapy, and a disease then would move into the realm of what we call precision medicine. And it's the shift from intuitive medicine to precision medicine that, in our view, is the technological enabler behind the ability to disrupt the medical industry. Evidence-based medicine, telecom technology play key roles in doing that. Imaging technology, in particular molecular diagnostics, are unfolding lots of the mysteries of why patients wouldn't respond to the same therapy. So that's what we mean by scientific progress that drives the ability to disrupt or decentralize an industry. And for years, this just wasn't possible except in infectious disease. But we really do believe that molecular biology, working in cancer and then moving into other diseases, will play a key role in this transition. Now, we've depicted it here as three distinct realms. In reality, it's a continuum. And diseases move disease by disease, step by step, year by year, from one end of the spectrum to another. And of course, the diseases are spread out all along that spectrum. Now, the second thing is you got to develop a new business model in which the simplified solution can be delivered to customers in a cost-effective way. And we developed a simple way to think of what is a business model and how is it built. Always, it starts with the value proposition. This is what we're going to offer to the customer. In order to deliver, a company has to put into place resources. These are people, equipment, facilities, technology, products, cash that you got to have on hand to deliver the value proposition. Then as companies use those resources to do the delivery, processes coalesce, which are just habitual ways of working together. And then ultimately, a profit formula emerges for the company. And the profit formula defines how big you have to be to break even, what kind of margins do you have to generate to cover the fixed cost inherent in your resources, how fast do we have to turn the assets over to be profitable. The profit formula then determines the value proposition that the business unit or the business model can and cannot offer. And very quickly, it becomes locked, so that any innovation that fits the business model gets funded very well. And that's why established companies do so well on that blue trajectory. But if it doesn't fit, they have a very difficult time unless they create a new business model. So if I go back to the computing industry, IBM was the only mainframe computer supplier that made the transition to that next ring out, which was mini computers. And the way they did it was they made their mainframes in the Hudson River Valley. They sold hundreds per year. They had to generate 60% gross margins to cover the overhead inherent in the mainframe business. When the mini computer emerged, they set up a completely autonomous business unit in Rochester, Minnesota, and gave it the freedom to create a different economic model to compete in the mini computer world. So they had to generate 45% gross margins, and they sold tens of thousands of these units a year. And then when the personal computer emerged, IBM was the only mini computer maker that survived into PCs, and they did it by setting up yet again a different business model in Florida, because that one had to have the freedom to make money at 25% gross margins while selling millions of units per year. And then the next step was to create a services business. And you just get this vision that just like in biological evolution, individual organisms don't evolve. They just are born and they die, but a population can evolve as the mutants gain market share. And you get the same sense in a corporation, that the business unit itself doesn't evolve very well because of the interdependencies amongst these four elements. But by creating new business units, even while you shut the old ones down, a corporation has great flexibility to evolve. And in computing, IBM is the only one that evolved in that way. The others were just born and then died. Now, we concluded that a general hospital actually isn't a viable business model. In the absence of philanthropy, subsidy, and heavy regulation, most general hospitals would collapse of their own weight. And our conclusion for why is that they offer a really interesting value proposition. That is, whatever's wrong with anybody, bring it here. We will do anything for anybody. And that's a very hard value proposition to deliver on. In order to do it, they have to put into place a set of resources. That is, one of every kind of subspecialist, one of every kind of equipment. The processes in a hospital are very convoluted, as I'll describe next. And the complexity of that requires that for every $10 that is spent in a hospital, about $1 is spent directly caring for the patient, and all of the rest is absorbed in overhead that is inherent to the complexity that is caused by this value proposition that we will do anything for anybody. Now, we have a case in my course called Michigan Manufacturing Company. And Michigan Manufacturing makes axles and gearboxes for the auto and truck industry. And they've got 9 plants through the Midwest. And the setting of the case is the plant in Pontiac, Michigan, where the plant manager, Noel Allen, is showing a team of accountants from headquarters out the door. And they've just told Noel that they're going to shut down her plant because her costs are too high. It's not that her direct labor costs were higher than others, but her overheads. There was $6.2 of overhead spent in her plant for every dollar of direct labor. And they pointed out that there's a plant in Ohio that only has overheads of $2.2 of overhead per every dollar of direct labor. And so they were going to shift the products from Pontiac down to Maysville, Ohio. Well, as Noelle walked back into the plant, her puzzle was she couldn't see overhead anywhere. They hadn't painted the plant for 20 years. They didn't landscape it. There was no receptionist in the lobby. She went back to her office. She had no secretary. She worked out of this old gray World War II era steel case desk. And then when she went into the plant, it was laid out like this. So they had grouped the machines by type of machine. And the reason they did it was threefold. One is the equipment cost hundreds of thousands of dollars a piece. So if you group all of the types or all like machines together, you can manage their utilization optimally. They're complicated to operate. And so by grouping them by machine, you could maximize utilization of their skilled workforce. But the most important reason for this sort of a layout is that it was consummately flexible. They could make any axle or gearbox for any customer just by routing that product over a different sequence of operations. So what would happen is a customer would send a drawing for a new axle. Their engineer would examine the drawing and then decide what sequence of operations it should follow. So you'd bring the rod in for one particular design, you'd cut it off to length, and then you'd take it up to the turning machines where you, in a lathe, you machine the outside diameter precisely. Then you take it over to the hobbing department where you cut gears into it, down to the annealing furnace where you let the steel relax, and then take it into the boring machines. This is not ennui type boring, but the drilling of holes. Then you'd tap screw threads into it, deburr the stuff, let the steel relax in the annealing furnace, polish it, and then ship it off. If it was a gearbox, it would start in a different spot, probably down in the stamping machines, and it would follow a different sequence of operations through the plant. And the beauty of that is that this plant could design and manufacture any design of product for any customer. Well, Noelle then went down to Maysville, Ohio to try to find out what was the secret of their having such low overheads. And when she drove up to the plant, she could see overhead everywhere, beautifully painted and landscaped, receptionist in the lobby, the plant manager had a secretary. But then when she went in the plant, it was very different. What they had done is 20 years ago, they had taken the 2 highest volume pathways or sequences of operation out of the Pontiac plant and lifted that sequence of operations out, brought it down to Ohio, stretched that thread out in a long line, and offered a very different value proposition. And that is, we will not do anything for anybody, but if you have an axle or a gearbox that can be fabricated by following this sequence of steps, bring it here, because we can do it at very low cost and very high degrees of product quality. And so she realized that she wasn't inferior or superior, but the 2 plants just offered very different value propositions, both of which were important. So we then had a chance to go in and look at the other 7 plants in their system and develop this algorithm that helped us measure the cost of that complexity. So every time they doubled the number of pathways that different products were following through a plant, it increased the overhead cost in that plant by 30% per unit. And that's why Noelle Allen's costs were so high, is that by trying to make 24 different product families defined by 24 different pathways through the plant, the complexity of managing all of that stuff drove her overheads high. So if I took off the names of these types of machines and showed you that chart, would you tell me that it's a schematic of an axle plant or a general hospital? It's exactly the same thing, isn't it? Because a general hospital's value proposition is just what the Pontiac plant was. That is, we will do anything for anybody. And as a consequence, they have to keep all of these things as separate islands so that they can route any given patient over any sequence of operations in order to deliver on that value proposition. One of our co-authors, in addition to Jerry Grossman, was a MBA, MD student of mine named Jason Huang. He went back to UC Irvine and figured out after studying it for some time that there were about 110 different pathways that a patient might follow through that hospital. Now, in order to deliver on this value proposition also, the hospitals really have become expensive conflations of three fundamentally different business models. So, and there really are just three types of business models in the world so far as we've been able to tell. One type of business model we call a solution shop. And a solution shop is a business that diagnoses problems and recommends solutions. So for example, McKinsey is a solution shop. You pay these guys a boatload of money. They'll send a bunch of experts in and diagnose what's wrong with your company and recommend solutions. The diagnostic activities and the practice of intuitive medicine in a hospital, where you develop a hypothesis, apply a therapy to confirm or disconfirm your hypothesis, is a solution shop type of activity. Invariably, solution shops have to be paid on a fee-for-service basis. Now, occasionally there have been consulting firms like Bain & Company in the Boston area that have tried to get compensated based upon the outcomes of the recommendations that they make, but they always have to punt, because in that kind of an environment, the outcome depends upon so many other things besides the quality of your diagnosis and recommendations, that they end up just having to live with a revenue model that is fee-for-service. The second type of business model we call the value-adding process business, and this is a business where you bring stuff in that's either incomplete or broken, you do stuff to it, and then you ship it out the door. So a lot of manufacturing is a value-adding process business, but education is too. And we just every year bring in about 900 very incomplete people to the Harvard Business School, and then we do stuff to them. And at the end of 2 years, we ship them perfected down to Wall Street. Restaurants are value-adding process businesses, and medical procedures that are performed in a hospital or a clinic after a definitive diagnosis has been made look a lot like a value-adding process business model. Value-adding process business models typically make money on a fee-for-outcome basis because the ability to deliver the outcome is very predictable. It's embedded in process and equipment. Then the third type of business model we call a facilitated network, like telecom. Insurance is a network-type business. And these business models tend to make money on a fee-for-membership basis, or sometimes a fee-for-use basis, evolving towards membership. And it turns out that network business models actually are a lot simpler and more effective in the long-term care of chronic disease than other business models. And I think you'll see that the next speakers are going to show a facilitated network in the care of type 1 diabetes. Well, the problem that the CEO of hospitals face is hospitals are conflations of all three of these types of business models, in particular solution shops and value-adding process businesses. And so what should the revenue model be in a hospital? Because you're conflating two fundamentally different, or inherently different business models. And it's kind of like you merge Whirlpool's manufacturing operations with McKinsey's consulting business and try to report the results on the same income statement, try to measure quality of the two activities by the same metrics. And I think one reason why hospitals struggle to report publicly meaningful data on their costs and their quality is, in fact, their conflations that are almost unmanageable, that have just evolved over time. Now, oh, this is a great story, but I better not do it. So what we see having to happen is there will always be a need for a Mayo Clinic type hospital where you got multiple systems of the body interacting. But for most hospitals, they actually need to be divided up. And so one of the recommendations we made in our book is we need to take out of the hospitals the procedures that are performed after a definitive diagnosis and put them into value-adding process clinics. And we see these around, orthopedic clinics, hernia clinics, eye clinics, and so on, just as an indication of what kind of cost savings come when you do that. If you compare the Shoulder's Hospital north of Toronto that does only hernia repair versus a general hospital, Shoulder's just has one product pathway through the hospital. A general hospital, UC Irvine, has about 110. You compare the costs of those two, the cost of supplies and direct labor is not appreciably different, but the overhead cost difference is just enormous. And so the cost of having your hernia repaired at the Shoulder's Hospital is about 40% of the cost of doing it in a general hospital, and all of the cost difference is attributed to the lower overheads that are inherent in a less complex operation. Retail clinics are another example of taking moving into a value-adding process business model, the kind of things that are done in a doctor's office, which is a solution shop. And again, they reduce the cost by roughly half of what it costs in a doctor's office. Then the next thing that needs to be separated out of our hospitals are solution shop activities. And to give you a sense of why I think they have to be separated out, I have a friend, Dave Snow, who's the CEO of Medco. And Dave has suffered from asthma his whole life. In his language, he's been to dozens of specialists. Each one has added to, subtracted from, or multiplied the number of medications he was taking. At one point, he was taking over $1,000 a month of medication. Nothing would help. And then Dave heard of this outfit in Denver called the National Jewish Medical Center. And National Jewish, in our language, is a solution shop for pulmonary and respiratory disease. So Dave flew out to National Jewish, and on day one, they administered a standard body of tests. On day two, they sat him down in a room, and in walks an endocrinologist, a pulmonologist, an ear, nose, and throat specialist, and an allergist. And they just sit down around Dave and started to argue with each other. Look at the data, ask Dave questions, argue some more. And after about a half hour, the leader of the group stopped and said, "Okay, Dave, I think we understand. The reason why you haven't responded to any of those medications is you don't have one of those types of asthma. Asthma is a disease that is in the realm of intuitive medicine. Wheezing is a symptom shared by multiple different causal disorders, and Dave had been treated for types of asthma that he did not have." And they said, "Dave, today's your lucky day, because for the type of asthma you have, there's just a generic drug that's going to take care of it just fine. Now, to be sure, we want you to stay one more day. We'll stress test you." But it worked just great, and Dave flew home. Now, on his way back home, Dave asked a couple of interesting questions. He had seen each of those subspecialists, or those types of subspecialists, many times over the course of his career of treatment, but he always had seen them as individuals. And then he was passed to another individual and then another, because the structure of a hospital deliberately decouples the caregivers to maximize the flexibility to route a patient to do anything for anybody. And these diseases that are still in the realm of intuitive medicine are there because they often arise at the intersection of multiple systems in a body. And as soon as they converged all of the relevant perspectives on Dave's problem, they got the insight. In other words, our hospitals think that they're integrated, but they're actually not integrated in the correct way to do either of the things that most patients need, which is, would you please diagnose what's wrong, and would you please reliably fix this problem? So there is not a patient whose job is I need an institution that could do anything for anybody. The patients have a job to do, which is I need a precise diagnosis and I need an effective therapy, and hospitals just aren't integrated correctly to do either of those things. But there are institutions like National Jewish and like Schuldis and the Aravind Eye Hospital and orthopedic clinics that actually are integrated correctly to do things affordably and simply. Now, the second question that Dave asked as he came back was it cheap or expensive for Dave Snow to fly to Denver to get a precise diagnosis of his disease? It was dirt cheap. And we've thought about this a lot because there are a long range of chronic diseases for which there is no solution shop that would even attempt to give us a more precise diagnosis. So, for example, we know today that type 2 diabetes isn't a disease. Elevated levels of blood glucose is a symptom that's shared by at least 12 different disorders. But think about how the healthcare system treats a patient with that symptom. You got fasting blood glucose of 183. This is your body mass index. You're obese. You have type 2 diabetes. Take metformin, lose weight, come back and see us in 4 months. And that's all of the energy that's applied to diagnosing a disease which is not a disease. And I bet you that if our healthcare industry would structure solution shops around some of these horrific diseases that are not diseases, that we're a long way in many of these from biomarkers, but we could shift a lot of these diseases from unstructured trial and error intuitive medicine to the realm of pattern recognition. And that would accelerate then the development of the biomarkers that would move some of these diseases into the realm of precision medicine, where then much lower cost caregivers could provide much more effective care. Now, just 2 thoughts about the care of chronic disease, and then I'll finish. Chronic disease accounts, as you know, for 75% of our healthcare bill. Diagnosing what type of these chronic diseases we have is a horrific problem and drives most of the cost. But then we also have the problem of getting the patients to adhere to the therapy that has been prescribed. We decided that you just don't want to call chronic diseases, but they can be delineated along 2 dimensions. One is the degree to which behavioral change is required. On the left, you just take a pill. On the right, you have to dramatically change the way you live your life. On the vertical axis is a measure of some motivation to adhere to the therapy. When the consequences of not adhering are felt immediately, compliance is not a problem. But when the consequences are deferred, then you got a big problem. And so Crohn's disease, if you don't follow the diet, you immediately suffer from that. And so even though it entails enormous behavioral change, patients do it because the feedback is so decisive and immediate. There are others where you just have to take a pill. You forget to take a pill because the consequences of osteoporosis and hypertension non-compliance are deferred for many years. There are others where you immediately feel it, although they don't entail behavioral change. Clay wears his glasses every day because if I don't, I immediately feel the consequences, and so adherence is not a problem. The big problems are in the lower right, where the consequences are deferred and extensive behavioral change is required. And we decided that the healthcare industry is just guilty of what we call business model malpractice in a huge scale. Because although doctors' offices could be really good as a business model for following or tracking patient diseases on the left-hand side, doctors can't make money ensuring the follow-up for things on the right-hand side. Things in the upper right, the patients actually know more than the physicians about how to live with that disease, and so you see user networks emerging where patients can teach each other how to live with these diseases and avoid the complications. We see in the lower right-hand side, a much deeper need for employers to get involved in helping their patients manage their care. As it turns out that about 15 to 20% of all, I'll call them patients or people, will prioritize staying healthy when they're healthy. The other 80 to 85% of people, when they're sick, they want to become healthy, but when they're healthy, they don't think about health. And that's why when companies offer wellness programs, only the healthy people sign up. When you go to the gym, it's all the people that are physically buff that are on the exercise equipment. And if you make it easier for people to do what they're not prioritizing, they just don't do it. And wellness programs suffer that problem that most people don't want to think about health when they're healthy. But they care a lot more about their wallets than they do their physical health. 75% of employees have 401ks, whereas only 20% of them will enroll in fitness programs. And employers are able to manage the linkage between financial health and physical health in a much more tractable way than any other institutions in society, because in many ways employers have a bigger stake in the productivity and health of their employees than the employees themselves feel. And so we really feel that one of the key mechanisms, or two of the key mechanisms for making chronic disease higher in quality and lower in cost is invest in diagnostics and then to use the right business models to oversee the adherence or to help the adherence to the prescribed therapy. Well, I really appreciate your patience in listening to me. There's a group in Boston that has an NPR radio show every Saturday called Car Talk. And Click and Clack, the Tappet brothers say, as they sign off, you've wasted another perfectly good hour. And I hope that this perfectly good hour of yours hasn't been totally wasted. But I would love to engage with you on some of these hypotheses that we have developed here in the hopes that they would be helpful to you and that I can learn something in return. Well, thank you very much, and I hope you have a wonderful conference.